Here we are, we made it to another Friday, everybody. This is COPD Navigator Live. My name is Mike Hess. I am a respiratory therapist and COPD educator. Also run a group here on Facebook. You can see down below, facebook.com/group/COPD Navigator. Where we, every Friday around noon, we do one of these excellent, in my personal opinion, talks about the latest and greatest news in the world of COPD, plus a particular topic of the day. This week we're going to be talking about having an action plan in your COPD management, as part of your COPD management. Our goal is to optimize everybody's self-management of COPD and to get everybody on the same page with a lot of this stuff, so that is our attempt today. But first, as we often do, we are going to start with some of the latest news from the world of COPD, and this is actually some of the very latest news coming out within the last couple of days. First off, we have a new report from the CDC. The CDC every week puts out what they call their mortality and morbidity weekly report, which is kind of the weekly epidemiological diary of the United States, more or less, where they take a look at various diseases, get a lot of information from various state health departments from around the country, compile it, look at some long-term data, long-term trends, all that kind of fun stuff, and issue these weekly reports. And this week was focusing on COPD. In particular, they took a look at some of the, believe it or not, latest available data, which came from 2015 on the Behavioral Health Risk Factors Survey. And they found that rural residents, people who lived in what are defined as rural areas, tend to have a higher burden of COPD than people in their more urban counterparts, whether you live in the suburbs or you live in an actual city. I think they called one of them a microplex or something like that, a micropolitan area. At any rate, people who live in more remote places do tend to have a higher disease burden and a higher prevalence of some of the other issues involved with COPD. In particular, the CDC found that people who live in rural areas have a higher prevalence in general. They had a higher rate of hospitalization, and they had a higher rate of death from COPD, again, as compared to their more urban counterparts. And again, these are tend to be controlled and evaluated to get rid of some of the confounding factors, to try to match people as close as they can between the two areas so that they can take away some of the questions there. And so the CDC also, as part of this report, also takes a look at some of the ways that we can probably fix that. Of course, we can have a lot of this data, and unless we're actually doing something with it, it doesn't really do anybody any good. And so the CDC wanted to know why these issues came to be, and they found, which probably will be no surprise to anybody who actually lives in an urban area, a couple of factors seem to contribute mightily to the idea that people have more severe, heavier COPD burden. First off, there tend to be a little bit more smokers in rural areas. Now, this is one area where I might take a little bit of exception with the CDC, not necessarily with the idea that there are more smokers in a rural area, but I think we have to do a lot more research about the level of pollution that we see in urban areas, whether it's car pollution, whether it's industrial pollution, or what have you. I think we're kind of putting that on that extra burden on rural cigarette smokers, perhaps a little bit unfairly, because we don't have a lot of data as to how much air pollution contributes to chronic lung disease. I think that data is coming out, and I think what we have does tend to show that air pollution plays more of a role than we thought, or than we have anticipated in the past, at increasing that rate of severity. But for better or for worse, we're still looking at that, and the CDC feels that right now some of the issue is driven more by tobacco smoke. In addition to higher rates of tobacco usage, people in rural areas do tend to have lower access to tobacco cessation programs, effective tobacco cessation programs in particular, because they are time and resource intensive. It takes a lot of time, takes a lot of effort to get these programs going, a lot of follow-up. so that and those areas or those concepts, as we know, are probably a little less available in rural areas where there are fewer people to begin with, fewer clinicians, which is kind of the ongoing theme between some of these other barriers that the CDC has found. People in rural areas tend to have limited access to relatively early diagnosis because they don't have access to clinicians who have and use spirometers and that sort of thing. And there's also lower access to pulmonary rehabilitation programs, which even under the best of circumstances tend to go underutilized. When we see them in areas where there are fewer clinicians available to do that, obviously we have a bigger issue. So again, the CDC looked at those factors and tried to come up with barriers to improvement. Some of them are very simple, like the simple idea that it takes longer and more travel time to get anywhere, which makes it logistically more difficult to access these programs. It's harder to pack up all your stuff, especially if you're somebody who uses oxygen, to get up and go to these programs. There's also one that I found a little bit interesting was the CDC attributed some of this to cultural perceptions on seeking care, and I wonder how that goes and how much of that is kind of the stereotype of the strong, independent, rural person who doesn't seem to or doesn't seek a lot of help because they're going to gut through everything. If that is the case, if you happen to be one of those people, I urge you to try to communicate with your provider so that we can take care of you. There's not a lot of benefit to trying to stick out something like COPD. That's not a very successful strategy in my personal opinion, but we can do things to help you live your best quality of life. So if you do fall into that category, I hope we can find a way to make it a win-win and get you cared for. In addition, absence of services, particularly pulmonologists and pulmonary rehab, which puts the burden of care more on primary care providers, who are among the first to admit, usually, at least on surveys, that they are not properly equipped by the healthcare system to manage a complex disease like COPD. We've talked about that many, many times in our group. It's difficult to have some of that access for, again, primary care under the best of circumstances, but in rural areas it's even more difficult. And finally, of course, a financial burden. I'm sure I don't need to tell anybody watching this that COPD does have a fairly heavy financial aspect to it, whether it's medications, whether it's equipment, whether it's services, and that's a big burden for a lot of people. So, next up on the news, if we can get this to properly come up here. It looks a little bit funny, but we're going to try to make it work. The wonders of technology, of course. We can adjust it a little bit. We'll get it fancy for everybody. If it doesn't work, we can do better next time. But this news is the American Cancer Society has released a new position statement on the use of electronic cigarettes for tobacco cessation. It's probably going to surprise a lot of people. It kind of surprised me a little bit. And they find that using electronic cigarettes is actually acceptable in getting people to quit smoking if it's used as a method of last resort. We see a lot of people, of course, we want to stick with the more evidence-based, the more traditional methods of tobacco cessation, using nicotine replacement, patch, gum, all that kind of stuff, counseling, medications, the anti-addiction type of medications. We do want to see those things still in use, but of course those are sometimes people have issues with those. They don't want to try those. They don't want to make those attempts. They are reluctant to do them. They felt that they haven't worked in the past, so they're trying to move on to something different. In these cases, it's felt, particularly in the short term, that electronic cigarettes offer less risk than traditional, what they call combustible cigarettes, the traditional tobacco cigarette. And so what we see is kind of a loosening of some of the rules here, at least for people who are existing smokers. Of course, we don't recommend anybody pick up electronic cigarettes, particularly the youth population, which seems to be a little bit more interested in some of these, and they tend to look at it as kind of a gateway to some of those combustible tobacco cigarettes. So we're definitely trying to discourage use in those populations, but we do see some utility in trying to use e-cigs to get people to quit. One of the most important things is we do want people to quit using both at the same time. Actually, I had a conversation with a patient of mine this week about that, using some tobacco, using some electronic cigarettes, and my opinion, and I haven't done a lot of specific research in this particular aspect of it, when you have tobacco cigarette, we know that when you smoke, you tend to have habits and rituals that kind of surround your usage of cigarettes, whether it's a coffee in one hand and a cigarette in the other hand, whether it's an after-dinner cigarette, what have you. You develop these habits and rituals around the use of a particular, we'll call it a device for the sake of our discussion here. When you add in a new device, like an electronic cigarette or a vape pen or whatever you want to call it, you're now developing two sets of habits, two sets of rituals, two sets of kind of brain conditioning stuff that then it's going to make it twice as hard to break when the time comes. So we do want to discourage people from using both at the same time, because there's obviously no benefit to doing that, but we do want to maybe push a little bit, take a little bit more of a push at using electronic cigarettes altogether instead of going back and forth at the same time. Again, we still want to avoid them for the youth population. We don't want to get people hooked if we can avoid it. And we don't have a lot of evidence in the long-term effects. So this is, again, not necessarily saying that this is a safer alternative or anything like that, but it is potentially less hazardous than traditional combustible tobacco cigarettes. So it'll be interesting to see how this continues to evolve and mature as other agencies weigh in, and we'll see how things are going. Last up on the news front today, kind of a fun piece of news here. We have, out of New Zealand, a report where they used a robot, actually, to help people transition from inpatient care out to inpatient in-home or outpatient in-home care, and how they could help people make that transition a little bit easier. So the University of New Zealand enrolled about 60 people who, again, live in rural environments, who don't necessarily have access to high-quality care and a lot of support and all that sort of thing, and took a look at them over the course of 4 months. And they found that when they were issued this robot, which is made by the same people who make, pretty much lots of different robots, from those little Roomba vacuum cleaner robots up to the big bomb disposal robots that police agencies use. They also made this COPD robot that you can see on the screen over here. And what this robot did was gave them some reminders for medications and exercise. It took a look at their pulse oximetry, their FEV1, that main spirometric data, took a look at their heart rate, asked them some questions about their symptoms, asked them some questions about their mental and emotional state, and then offered reminders and gave them some pointers on how best to manage their COPD. And what they found was people who had the robot had a higher rate of adherence to their medication regimen, actually about double the rate of people who didn't have the support robot. Also had a higher rate of completion of their in-home pulmonary rehabilitation exercises. What they didn't find was a change in the hospitalization rate. This robot also has a feature where you can push a button and say, I'm not feeling all that great. It takes a lot of these samples again with your pulse ox and all that sort of thing, and then connects that data, evaluates that data, and either tells you to call 911 or their equivalent, or connects them with a physiotherapist, which is kind of their equivalent to a respiratory specialist down in New Zealand, and connected them to try to get a better sense of where a person was with their symptoms and get that stuff evaluated a little bit better. So like I said, it did help with the management plan. It did actually offer people a sense of companionship that they felt was higher than they would get from a computer or a tablet. Actually, 75% of the people who were surveyed said that they preferred this method and had a positive sense of it, impression. But didn't really affect the hospitalization rate so far. So this is another one of those tools that is going to be helpful. are going to be a part of the whole telemedicine regimen type of thing, and get people more interested in how we can service some of those people and overcome some of those barriers that the CDC identified, even here in the U.S., to try to get people better access to the care that they need and the care that they're entitled to. So hopefully we'll see some more of that stuff coming out. The other thing I wanted to point out on here, this particular device was also highlighted on a website called CNET, which is a relatively mainstream website. So it was kind of cool to see a COPD-oriented device coming out and being discussed in a mainstream situation, so to speak. A term gets thrown around a lot these days with political discussions, but it was good to see, we'll say, a civilian, a commercial publication that focuses on COPD. Craig asks, when is it going to be available in the U.S.? It's difficult to say. This is the first I've ever heard of the device. I haven't really had a chance to look into it too much. I discovered it this morning as I was doing a little bit of, I like to sort of wait until the last minute to hit some of the COPD news stuff so I can bring you as most up-to-date stuff as I possibly can. So I haven't really had a lot of chance to dive into this a whole lot. My suspicion is that it's going to be a little while yet, but I would like to see, I would perhaps like to reach out to iRobot and find out some more information about how we can get this to people who need it, and do a similar study here in the U.S. I think it would be very valuable and very helpful to a lot of people. So that is kind of our news update for the day. I encourage everybody to get some questions in now. You can add them to the comment section as we go through stuff. Of course, if you're new to the program here, what we do is a news update, which we just completed. We do a little bit of a topic of the day. Today we're going to be talking about COPD action plans in the individual. And then afterwards, with our remaining time, we do have a lot of question and answer time. So anything that's on your mind, whether it has to do with action plans, whether it has to do with robots, whether it has to do with mortality and morbidity reviews, whatever it is, whatever's on your mind, we'll get those questions in, hopefully get them answered to your satisfaction at the end of the program here. So our main topic of the day, as I have kept harping on a couple of times here, is the use of action plans in COPD. Now usually when we talk about, most recently, we talk about the action plan, we're talking about this document, which is called the National Action Plan, which was issued by the Department of Health and Human Services, the National Institutes of Health here in the U.S., and has a lot of great information about how we're going to improve a lot of these aspects of COPD care as part of healthcare policy. But today we're going to dive down a little bit deeper, a little bit more granular. If we'll throw some fancy words out there. They say, never use a 2-syllable word when a 10-syllable word will do. And we're going to take a look at individualized action plans for people to increase your own self-management of COPD. These type of things have been endorsed or promulgated, pushed out there by all the organizations that you see along the side here from here in the U.S., the COPD Foundation, the American Lung Association, and around the world. We see the Canadian Lung Association and even the Lung Foundation Australia have all put out different types of individualized action plans. In Europe, we see a lot of these things come out there too. We have a lot of good reference materials in order to do that. So the big question is, why do we want to do this? And the answer is still somewhat evolving. The idea of having an action plan actually came out of the asthma world, as many of our chronic obstructive pulmonary disease concepts have. Many of them also have come out of the asthma world, and that's what we're seeing with these action plans. They've been in use for asthma for literally decades. There's been a lot of study out there, both in pediatric and adult asthma, trying to figure out how we can get people to better control their symptoms so that they can avoid the doctor visits, they can avoid the they can avoid ER visits, they can avoid all these exacerbations, or at least as many as possible. But we haven't really seen that a lot in the world of COPD. We did see a study back in 2009 that did show that these types of action plans did tend to decrease hospitalizations, at least in certain populations. Since then, reviews have been a little bit mixed because there are, a lot of, like I said, a lot of different groups that put stuff out there, a lot of different styles to go at this, a lot of different techniques. So we're going to take a look today at why we're going to do this, because while the specific idea of having an action plan hasn't really been studied, the idea of self-management in any kind of chronic disease, and specifically within COPD, has been studied. And we found that the better able people are to manage their own symptoms, we call it self-efficacy, the better people are, the better able, the more people, I should have had more coffee before I started today, the more a person is able to manage their own symptoms and kind of steer their own care, the better off everybody is. And another one of these aspects, I look at Dr. Brian Type, who's a pulmonologist out in California, does fantastic work in the COPD community, has done a lot of educational stuff. He always likens exacerbations, COPD exacerbations, to a forest fire. If it's something that you can catch very early, when it's small, it's easy to put out. You're not going to lose a lot of time. You're not going to have a lot of damage. You can get that handled very easily without a lot of resources. If you wait and let it grow and get worse and it quickly becomes unmanageable, then you need to call in a whole bunch of resources, which for forest fires are the firefighting planes and volunteers and everybody else coming in to handle that. In the COPD world, that usually means at the very least an urgent care visit, sometimes even the ER or something like that. Sometimes that sort of thing is unavoidable, but if we can get people a plan to recognize some of that stuff and have access to those materials at home and take care of a lot of that on their own, we can trust people to manage their diabetes on their own. We can train people to manage a lot of these chronic diseases. So why aren't we doing that with COPD? The COPD Foundation figures that these action plans have kind of a threefold benefit, where they improve communication between a person with COPD and their family or caregivers and their care staff. Along those same lines, it establishes the person with COPD as a true partner in their care, instead of just being told what to do, that kind of paternalistic type of concept that medicine has been for a very long time. And it improves efficiency. Again, we're catching that forest fire when it's very small, when it's early in the change in symptoms, and when we can do something about it fairly easily. The other thing we want to make sure is that each of these action plans is customized and is kind of an evolving document. We're somewhat getting away from the idea of COPD as a inherently progressive disease. We do feel it does have progression, but it's not necessarily the linear straight line decline that we've often thought it was. But we do want to make sure that we're able to adapt this document, because somebody who's newly diagnosed with COPD is going to have different triggers, is likely to have different triggers, is likely to have different symptoms, is likely to have a different understanding of what to do than somebody who's been diagnosed for 5 or 10 years and has had kind of a long course. So we want to make sure these documents are customized, but also flexible enough to change over time. And now every one of those groups that I mentioned earlier that sponsors one of these action plans has a slightly different take on it. What I'm going to use today is the action plan we have here at our clinic in Kalamazoo. And actually, I'll hold it like that. What we see is they all have basically the same concept, and again, this is something that kind of grew out of the asthma world, where you have kind of a stoplight. You have green symptom days, you have yellow symptom days, and you have red symptom days. The green day, shout out to all the alternative rock fans out there, in case one of my kids happens to be watching. The green days are when you're feeling your usual self, you're able to do your usual level of activity, you have your usual amount of coughing and mucus production and shortness of breath or lack thereof. You're sleeping okay, you don't have a headache, you're basically feeling your best self. This is where your normal symptom days, this is where things are going fairly smoothly. We like to write down what you're going to do on an everyday basis, because we also recognize that a lot of people are on fairly complex regimens. We've got people who are on multiple inhalers. We've got people who are on inhalers and nebulizers. We've started to throw some pills in the mix now as we're getting into those PDE4 inhibitors and the antibiotics and stuff like that. So we try to make sure that we're giving people a reference so that they can understand what their daily regimen is. Their oxygen prescription is right there. We encourage people to continue their regular exercise and diet plans, which is something we don't talk about enough in general in COPD. And of course, we want to avoid cigarette smoke and other irritants, if possible vape smoke, regardless of what the American Cancer Society says. If you can avoid all of this stuff, so much the better. Now, we also recognize that there are going to be days where you don't feel quite so good. Maybe you're not feeling sick, but you're feeling not so good. And that's the yellow flag, yellow stoplight, sort of caution zone. This is where maybe you feel a bit sick, and it's one of those things where you can't really quantify, you just don't feel great. A little bit harder to breathe than usual, maybe a little bit more short of breath with activity. We had a gentleman in the group last night who was talking about having felt like he ran a marathon every time he did anything, even the littlest activity. He ended up going into the ER and being diagnosed with early exacerbation or at least some kind of symptom flare. He mentioned it in the group this morning. So, David, if you're watching, hope you're feeling better. Hope you're taking care of yourself out there. You also have a little bit more cough than usual, or you're producing a little bit more than usual, or it's a different consistency, different color. Anytime you have one of those changes, we look a lot at the idea of mucus changing color as kind of a diagnostic thing, or the actual color of mucus as a diagnostic thing. Well, if it's yellow, it must be bad. Well, sometimes people produce yellow mucus even at their baseline. What we really should be looking at is when there are changes in color. That's when you can start picking up on a danger sign. Again, whether it's thicker, whether it's harder to cough up, whether it's changing color from yellow to green or from clear to yellow, whatever it is, a change is usually what's kind of indicating our danger there. You're using a little bit of extra rescue medication. Again, this kind of goes along with the increase in shortness of breath and that sort of thing. If you're finding you need to hit that rescue albuterol, whether it's an inhaler or nebulizer, whatever it is, that can be another inhaler on a scheduled basis. A lot of times we want to make sure people are getting ahead of their symptoms, staying ahead of their symptoms. When you're short of breath and you keep pushing, sometimes you run into more of an issue and you can push yourself kind of downhill, so to speak. So we want to make sure that you're as bronchodilated as possible. You've got a lot of your best efforts going out, and that sort of thing. Maybe turn your oxygen up a little bit. This is a case-by-case thing. We're trying to give people, again, a little bit more flexibility, as we're seeing that we do have to be mindful of some of the risks involved with using too much oxygen, especially when we're talking about portable tanks and things like that. But we also want to make sure people are getting the resources they need and the therapy they need. Now, here's where it gets really controversial in a lot of places. Use antibiotic and use corticosteroid. There is a fair bit of data to suggest that if we create what the United Kingdom's National Health Service calls a rescue pack, a COPD rescue pack, we can kind of position that in somebody's home. We can pre-prescribe it. We can get it back to putting it in their hands, and we can do a lot of good with catching this stuff early. In the UK, they have their rescue pack. Their standard rescue pack is 30 milligrams daily of prednisone, the corticosteroid, for 7 days, and an antibiotic called amoxicillin, 500 milligrams 3 times a day for 5 days. I also found there's a website that's called the Family Practice Notebook. I think it's fpnotebook.com. They suggest as part of the rescue pack, you have, of course, your rescue inhaler. They suggest a little bit more prednisone over a little bit shorter time. Again, we're getting into some of the newer data that shows bursts of prednisone, maybe just as well as some of those long tapers with fewer side effects. So this particular website said 40 milligrams of prednisone over 5 days, as well as an antibiotic. Their frontline things were doxycycline or amoxicillin for 5 days, or you could also, if those issues were, or if those had an issue, you could go with something like augmentin or azithromycin. Again, these are things that are going to have to be tailored. This goes back into some of that tailored kind of thing. Haven't done the red light yet. We're going to get to that in just a minute, so I'll hold to. I know we had a little bit of a technical glitch there. Apologize for that, but I tried to restart right where things left off, so we shouldn't have lost too much in the way of stuff. But again, as we're going through some of these pre-positioned corticosteroid and antibiotic packs, these are definitely things that you're going to want to talk with your provider about, whether it's your primary care provider or your pulmonologist. There is an increasing amount of data that suggests that these are actually a good idea. I know a lot of providers are a little bit concerned about making sure people are taking this stuff. We talk a lot about antibiotic resistance, and so if we give people just antibiotics willy-nilly, are people going to be jumping the gun and taking too many and increasing resistance and that sort of thing? I tend to, again, we trust people with needles. I look at the diabetes world a lot for inspiration in chronic disease management. We trust people to change their dose of insulin based on their blood sugar readings. We encourage people and empower people to do a lot of this stuff on their own. There's not really any super compelling reason we can't do that for lung disease, in my opinion. But these are things that you're going to want to talk to your clinician about and make sure that they are tailored to your individual case. People sometimes are on chronic antibiotic therapy and may need a different type of thing if they get colonized by a different type of organism. Some clinicians are going to be comfortable with people calling into the office and saying, hey, I'm starting my thing, follow up with me when you get a chance. Others are going to want you to call in and say, these are my symptoms, can I start? Again, this all has to do with being a partner in your own care. Your provider should be a partner with you and give you some options as to what the best practice or what your best strategy is. In my opinion, that is the best practice, and of course we're seeing that a lot these days, where when you are part of the care team along with your providers, you have a better course, you have a better outcome, you have a better course for your disease, you have lower levels of those exacerbations and that sort of thing. So it's very important to be a team player, and it's just as important for your clinician to be a team player too. And if they're reluctant for that, hopefully you can find one that is, or you can tell them, look, this is the deal, this is the way it's going to be. Remember that as the patient, you are also the consumer, the customer, blah, blah, blah. You have a voice. You have a very important voice, and you are entitled to say, I'm not comfortable with your care. We need to find a better solution here. I want to be the partner. I know my body. Pam, I mentioned that it's important to come to the understanding of getting to know your own disease. That is absolutely true. And I am of the belief that you, the individual, know your body better than I ever could. I can sit across from you, I can listen to you with a stethoscope, I can look at your pulse ox, all that stuff, but if you tell me that you're not doing better, or you feel sick, you feel that there's something wrong, I should be listening to that, because you know you better than I do. I'll cover a lot of that, some more stuff that Pam says, and we'll get to Jim and Mary's stuff in just a moment here. Because I think I'm going to cover some of this stuff as we go through here, but I do want to mention that as we get past the controversial parts, some of the less controversial things, we do want you to relax a little bit, try to get some extra rest. Of course, it's harder to fight off these symptom flares when you're feeling stressed. You're already going to be feeling stressed because you don't feel very good. We do want you to take care of yourself when you have these symptoms, because it's going to be easier for you to recover when you have as much rest as you possibly can. Of course, again, when we talk about sleeping issues and all that stuff, it's kind of hard to do that. Sometimes you got to do it when you can. Make sure you're using your good breathing techniques, your pursed lip breathing, your huff coughing. If you have an oscillatory PEP device, one of those aerobicas or an acapella, something like that, lung flute, whatever device you prefer or have access to, make sure you're using those to help bring up anything that you can. And if those symptoms last, in our case, we say 24 to 36 hours, we want you to give us a call. We have not gone to the whole preposition thing yet. What we say is we recognize that there are going to be times where you have bad symptom days that aren't necessarily the beginning of an exacerbation. And that's where a lot of this stuff really comes in. Again, knowing your disease comes into play. COPD can be a very inconsistent disease. You can be feeling fantastic one day, and then the next day you're down here, and then sometimes you're feeling just fine the next day again. Maybe you came across one of your triggers, or you were around somebody who had too strong perfume, and so the whole next day you're just kind of feeling like garbage because you're still trying to flush out those bronchospasm triggers. But that doesn't necessarily mean that you are in a full-on flare. When we see these symptoms persist over a day, maybe 2 days, that's when we start really getting concerned. Again, it's going to be different for every person. Sometimes people might have 3 good days, 3 bad days, 3 good days, 3 bad days. And in those cases, when you get on to the 4th bad day, that's when we're really going to want to be taking a look at some of those flares and stuff like that. Again, critical to have this individualized to your care and flexible as things change over time. So we do want you to give us a call, whether it's our regular number or after hours number, so we can make a determination if you need to run right now to urgent care or something like that, or be able to be seen the next day in one of our urgent appointments, so on and so forth. Again, all things that you're going to target to your own needs and your own issues. Last but certainly not least are the red zones down here. This is when you get really short of breath at rest, you can't sleep, you've maybe got a fever, you're getting chills, you've got chest pain, you're noticing a little blood when you're coughing stuff up. These are when we don't want you to wait anymore. This is when you're going to call 911, you're going to go to the ER, you're going to do whatever it is you need to feel safe. Still maybe doing some of the yellow zone stuff, making sure you're taking your rescue medications as appropriate while you're waiting to get into the ER, all that kind of thing. We want to make sure that you're taking care of yourself while we're calling in the backup and getting you taken care of. On the back of our action plan is a lot of reference materials. We like to fill out who your primary doctor is, your pulmonologist if you have one, after hours numbers, which we cover a couple different things, your emergency contact. A lot of times people know that stuff or they have it in their phone these days, but we do have certain cases where we're going to want to have a very quick reference for that, especially for caregivers or support people and that sort of thing. Also, we recognize that a lot of times there are some cognitive issues that go along with COPD and with advancing disease and even some advancing age sometimes, and it may not always be clear what your baseline symptoms are. So we like to have kind of a reference for that particular population where, if I'm feeling good, if I'm feeling my usual self, I can clean the house just fine. But maybe sometimes I have some limits on brushing my teeth. And so we have kind of a reference chart for where we figure we can put people, and so if they notice changes in these particular things, that might be a trigger that we're having an early exacerbation. Some other descriptors about, what's your usual breathlessness level, that sort of thing. We also have some handy tips for anybody with COPD, just general management stuff, eating a good diet, make sure you're planning ahead and pacing yourself as appropriate. Don't smoke, of course. Make sure you're drinking an appropriate amount of water. Exercise, get support. Join a support group, whether it's an in-person Better Breathers group, whether it's a group like COPD Navigator online here. Whatever it is, make sure that you're getting the support that you need. Now, again, a lot of this stuff is going to be tailored to your individual needs. We don't necessarily have a lot of direct information that action plans in and of themselves are going to be a lot of benefit to get people out of the hospital, keep them out of the hospital, and that sort of thing. But even the most recent Global Initiative for Chronic Obstructive Lung Disease, GOLD recommendations, do mention that self-management, education, and coaching by health professionals should be a major component of the chronic care model within our delivery system, which translated to simple English is it's critical for people like me, respiratory therapists, nurse practitioners, physicians, pulmonologists, primary care, wherever we are. It's critical for people like us to have people living with the disease as partners and making sure that you can take care of yourself as much as possible. We don't necessarily want you to be waiting on our direction all the time because you're losing time, you're losing lung function, you're losing time with your life, time with your family, time doing the things that you want to do while you're waiting for us, and that's not cool, in my opinion. I want people to be able to take care of themselves as much as possible, and that means it's up to us to make sure that you have the information and support that you need to take care of your particular disease. It usually takes the form of one of these COPD action plans, a personalized, individualized action plan, and making sure that we are your partner in care, and making sure that you understand everything that is going to give you the best outcome possible. So, climb down off my soapbox a little bit there before make sure that everybody knows that if you do have some questions, whether it is about action plans, whether it's about any of the other stuff we've talked about today, or whether it's just something that has come up in your care and you want to get some more information so that you can go to your clinician and say, hey, I heard about this, I want to try a different strategy, please feel free to get those into the comment section. We've got some time left. I want to make sure we get those covered. However, while we're waiting on that, I do want to go back a little bit here. First off, we're going to finish up what Pam was talking about here, getting to know the understanding of your own, or getting an understanding of your own disease process. She mentioned some of her own experience. Last summer, she wasn't sick, but breathing was terrible and not quite right. Again, this is one of those. A lot of times we would call that a yellow zone kind of thing, where you're just feeling kind of gunky. Went to the pulmonologist, listened to lungs, didn't hear anything, went for another month, finally decided had to do something. She hadn't had a PFT in a while, asked for one to be done, saw some worsening numbers, finally got a blood gas, had some chronic or some CO2 retention, carbon dioxide retention, upgraded to a non-invasive ventilator at home, which can be very helpful. A lot of times at rest, we use those while you're resting to take some of the burden off your respiratory system, help you take deeper breaths, more effective breaths, that sort of thing. There are even some smaller models out there that are helping with activity. And she says, I don't know how long I would have stayed very ill if I hadn't called and asked to have a PFT done. We need to be our own best advocates. And I cannot agree more with that. Again, it all comes back to being a partner in care, speaking up for yourself, not being afraid to challenge your provider. A lot of times, and I include myself in this, I kind of sit there and, okay, yes ma'am, yes sir, I'll do what I'm told, all that sort of thing. It is critical when we have a complex chronic disease like COPD, that you aren't afraid to ask questions and you aren't afraid to challenge us. Pulmonologists, everybody, we're human too. I had actually a pulmonologist tell me that a couple weeks ago. Pulmonologists are people too. We're human. We make mistakes. We aren't always up on the most current research, or we haven't seen the latest thing come in. Respiratory therapists like myself, same way. Nurses, doctors, we're all human. I always encourage people to, if you have a question, ask. If you disagree with something, tell me why, and we can work together to make that happen. So thank you, Pam, for sharing that. Jim and Mary, would it be feasible for the patient to develop with their doctor a list of things to watch for, possibly with actions to be taken? I have a list from my transplant team taped inside the cupboard door showing the symptoms that should drive me to the ER. That list should be readily visible. Again, wholeheartedly agree. That's why, sometimes, we could even do a thing like this where you have your action plan, you have your symptoms on the back, laminate it. Laminate it so that things can change over the course of time, if we want to do it quickly. One of these should probably be evaluated at least annually when you have an encounter with your provider, whoever is managing your action plan with you. Absolutely, you should have a list of things. Again, this kind of ties into knowing your disease, being a partner. Everybody's going to be a little bit different. Again, we talked a little bit earlier, some people produce a lot of mucus at baseline. So if they're producing a lot, that's not necessarily a trigger. But if the color changes, that's going to be an issue. So we want to make sure that everybody understands what to look for in their individual case. Whether that's feasible, that's going to depend on your provider. I'm hoping as we continue to develop how we're going to implement the National Action Plan, the big fancy document we were talking about before, as we learn how best to develop some of that stuff and implement some of that stuff, And as we can deploy more respiratory therapists out there to take some of the burden off of particularly our primary care population, I think we're going to see more of that. I have the time to, with a lot of my people, we can go through and we can talk a lot about this stuff. On an average day, how often are you taking your inhaler? How much are you coughing up? How are you doing this stuff? And then I can target a lot of that stuff. We see in the primary care world in particular, and again, we can go back to that CDC stuff with the rural versus urban divide. A rural pulmonary or a rural primary care provider may have a whole town of people because they're the only one. And so in order to service all those people, or even, when we talk about some economics sometimes, when we get into the economics of healthcare, unfortunately, we see our primary care providers pinched for time. I've mentioned this before a time or two, where your average primary care visit is only about 16 minutes long and has to cover 5 or 6 topics. That in and of itself isn't necessarily enough time to develop one of these plans, so maybe it's not as feasible for that provider. But if we get a respiratory therapist in there who can take some of that load off, then it becomes feasible. So we're really looking at a couple of different avenues to try to get these things implemented. In many cases it is feasible and it's always recommended, but whether your provider will play along with that unfortunately is something that you have to talk to them about a little bit, and hopefully you can push them in that direction, push them toward modernization. And then we're going to go back a little bit, way back toward the beginning. John, I appreciate your patience here, asking to take a look at the chart of the U.S. in the morbidity and mortality weekly report. Why do you think extreme northern Maine has a disparately higher prevalence of COPD? I have not actually seen that map off the top of my head, but when we're talking about extreme northern Maine, we'd be talking about a particular fairly rural area. We're probably talking about an area that relies a lot, based on the geography, on wood-burning stoves and that sort of thing for heat and possibly even for cooking. We see in those very rural areas a lack of access to early detection. We see a lot of factors going on there that will probably tie into that. I hate to throw another $15 word out there, but we use the word multifactorial to describe something like that, where there are a lot of things, kind of like brewing the perfect storm. We come up with a lot of stuff. There are a lot of factors that actually push higher prevalence in a lot of these rural areas in general, and in what would be likely to be a very rural area, northern Maine, we would see. I think it tends to be one of those progression kind of things, where the more rural you are, the higher these issues, the more significant these issues are. So the more rural you are, the less access you're going to have to pulmonary rehab, early detection, all that kind of stuff. In addition to the higher cigarette rates, the higher wood-burning stove rates, all that kind of thing. We see, I briefly did some work for a group called the Forum of International Respiratory Societies, and part of their strategy was looking at some of the developing world, looking at lung disease in those settings, and they found that places who rely a lot on biomass fuels, wood-burning stoves, all that sort of thing, they do tend to have a higher prevalence of COPD. And that's why, again, calling back to these mortality reports, I take some issue with putting it all on tobacco smoke, and saying people in rural areas are more prone to smoking, and so they have higher COPD, because it's that air pollution. We might not have wood-burning stoves in the city, but we do have a lot of factories, we have a lot of the air pollution, we have a lot of vehicle pollution. So I think that may be less of the difference in tobacco smoking rates might be a little less of a driver than we assume it to be. So without looking at the map, hopefully I answered that question to some degree. It's something I would like to come back to at some point when I can dive into it a little bit deeper and maybe have a more definitive answer, because it's a fascinating area to study. And on a personal note, it ties in with some of the epidemiology work I'm doing for my master's in public health right now. So that's a great starting point. We will revisit that at some point. Craig mentions, always make my doctor's appointment as early as possible in the morning. That gives me more time to talk to the doctors. Nobody wants the early morning appointments. I think that is a fantastic strategy. A couple of reasons. First off, people do tend to in many cases, you do tend to have a little bit better lung function in the morning, so it's a little bit easier to get around sometimes. This is where a lot of those controller meds are kind of peaking after you've been up for an hour or so. You're getting maximum benefit from those. Your providers have not fallen behind for the day. Excuse me. My wife works in an office where she wants to give everybody the attention that they deserve and are entitled to, and so sometimes in a 20-minute block, if you have a 22-minute appointment, and then you have a 23-minute appointment after that, now you're 5 minutes behind, and then maybe you have a 25-minute appointment, now you're 10 minutes behind. That stuff builds up over the course of the day. I've seen that with my primary care provider. We see it all the time. So if you can catch them in the morning and catch them early, that's certainly before they're falling behind, maybe when you have your best breathing pattern. And it does tend to be a little bit easier to get in there. Nobody likes that 8:30 appointment. So it's a great tip from Craig. Appreciate you putting that out there. I want to take a moment to say hi to a couple of Lindas, Linda from Alabama, Linda from Lansing area, Michigan. Appreciate everybody stopping in. Janice, nice to see you. Hope your doctor's appointment went well. Diane, another Michigander here. Hope everybody caught back up. Linda from Pennsylvania. She loves the information. Well, I love your support. I appreciate you stopping by today. Elena, nice to see you. Hope you're feeling better. I know Elena's been a little bit under the weather lately. Hope recovery is going well there. So hope everybody is having a great day today. We got a couple minutes if everybody's got some last minute questions. Otherwise, we'll take a look ahead to next week. We're going to be talking about a concept called do not do in COPD. The topic for next week came out of a news item from a couple weeks ago, where there was a study that came out from somewhere in Scandinavia, I believe it was, where they looked at some overutilization of stuff in chronic lung disease. Some things that some of the things that keep being done because we've always done it that way, and so we're looking at trying to optimize our utilization of particular things, figure out who best benefits from steroids, figure out who most benefits, what the best time frame is for pulmonary rehab, all that sort of thing. So we're going to be taking a look at, they came up with about a dozen different things that are overutilized, in some cases underutilized. It's a do not forget to do kind of thing. We're going to be taking a look at that next week. It should be a good talk. I'm looking forward to that one. Hello, Ida from Virginia and Rose from Kansas. Susan mentions, I cough and have white phlegm and chest gets very tight. This goes on at least 5 times a day. That may be a symptom that you are not being optimized properly. Of course, everybody with lung disease, not everybody, but many people with lung disease do have that kind of chronic cough and chest tightness. That is something that we look at as part of our routine evaluation. We have what's called a CAT test, or a COPD assessment test. We look at that. I look at that at every visit that we have, and of course, one of those is you mark off whether you have no phlegm or whether your chest is full of phlegm, or somewhere in the middle, and chest tightness, not tight at all, or very tight. So that is part of the assessment. Again, we look at, we try to establish a baseline. We try to figure out whether this is what your symptoms are and that's the way it's going to be, or whether we can improve that a little bit, whether there have been any changes. Symptom flares, again, we look at changes in symptoms. We look at, if you're having a lot of chest tightness or you're having a lot of mucus production, that's when we look at, do you need something like an oscillatory PEP, the aerobica, the acapella, all that kind of stuff. Do you need a different medication? Do we look back at some of your medication? Are you not on the long-acting muscarinic that you need, or do you need a steroid? So we look at some of those symptoms and we try to figure out where you are, and we make some changes on what's going on. That it's going on 5 times a day is perhaps an indication that things aren't going as optimal as we would like. So that's something I would definitely bring up to your provider the next time you're in to see them. White phlegm is fairly common. That is kind of the baseline normal phlegm. Again, that's everybody's normal is a little bit different, but that is one of the things that is fairly common. But if it's bothersome and you think that we could be, or that you think that your provider can be doing a better job, then don't hesitate to call them on it. So. Julie, Northern Michigan. Love Northern Michigan. Looking forward to, we go up to, depending on your definition, it's not, maybe not quite true Northern Michigan, Northern Lower Peninsula, actually an island off the Lower Peninsula. Throw a plug out there for Beaver Island. Our family loves to go up there every year for a week. We get a room up there, or we rent a cottage up there and spend a week kind of out in the middle of nowhere, and love it. Big fan of Northern Michigan. The whole northern Lower Peninsula and pretty much everywhere in the Upper Peninsula is some of my favorite place on earth. So glad to see you stopping by today. Julie asks, are there any new things on the near horizon happening for lung therapy and or transplants, coils, all that kind of stuff? We do have a talk coming up in a couple of weeks that's actually specifically going to focus on that. I can't remember how many weeks away, but it is coming up sometime in March. So take a look at our COPD Navigator. Take a look at the events in there, and we will be covering that in detail. Lake City, I love Lake City. As far as kind of the big overview of what's new, we do have a few things that are still working their way through the various approval processes that are becoming commonplace over in Europe, and we're trying to lean on the FDA a little bit more. The lung coils, we have seen some good results with those. The valves, similarly, these are things that are inserted via what we call a bronchoscope, where we don't have to necessarily make an incision throughout the lung. We can go down with our bronchoscope and we can install these one-way valves or these coils that can kind of reduce the size of the bad lung tissue.